Thanks, everyone. It's really wonderful to have me, for having me today. Such an honour to be invited to be a plenary speaker and stand alongside so many other wonderful and admirable speakers. My family were totally incredulous that I would be following someone like Stephen Fry. Anyway, they're my greatest critics. I better remember the clicker. Okay. So, hopefully we won't have death by PowerPoint, but I am going to, my talk is a bit scripted and I'm going to try and get through it as quickly as I can, so we do still have some time for questions. But first of all, I'd like to really thank Songwoman Marucci for such a beautiful and generous welcome, and also for Rob's comments as well in his acknowledgement. I also want to thank Amanda for the absolutely beautiful acknowledgement of lived experience, and want to say that I express my gratitude to those consumer activists who have had an integral role in driving change in mental health services in Australia, and to those who I work alongside and learn from every day. So the conference is privileged to have Professor Brian Burdekin here to remind us of the groundbreaking work of the National Inquiry into the Human Rights of People with Mental Illness. This systemic investigation was based on principles that reaffirmed that individuals who have experience of mental illness have the right to protection from exploitation, abuse and degrading treatment. The report recognised the right to be treated and cared for as far as possible in the community, and the right to treatment suitable to each person's cultural background. At the same time, the report emphasised the importance of treatment and care in the community being adequately resourced. The report repeatedly documented the failures across Australia to comply with these fundamental human rights standards. The report also detailed how people affected by mental illness suffer from widespread systemic discrimination and are consistently denied the rights and services to which they are entitled. It detailed how stigma and discrimination directed at people affected by mental illness is a major barrier to their full and equal enjoyment of life, and that this was completely unacceptable and must be addressed. It expressed concerns about our inpatient units not providing a safe therapeutic environment, the lack of alternatives when people were in crisis, police involvement in mental health crises, and thus criminalising the process and reinforcing stigma and fear in the community. The report also referred to how existing mechanisms to investigate grievances are frequently inadequate. It lamented people with psychosocial disability being excluded from the labour market and education, and thus being at risk of poverty and inequality. The report expressed concern about the lack of cultural safety in services and the overrepresentation of people who experience social disadvantage. When Professor Burdekin launched the report, he explained that one of the biggest problems for people affected by mental illness is the absence of adequate, affordable and secure housing, and that access to appropriate housing is often the most important single factor in the success or failure of those with enduring mental illness or psychosocial disability living in the community. Professor Burdekin went on to say that it is also appalling that homeless shelters, refuges and boarding houses are now functioning de facto as a major component of the accommodation provided by our society for thousands of Australians affected by mental illness. The living conditions in many of these establishments were found to be disgraceful. Few have trained mental health workers on staff, and there are rarely any decent opportunities for rehabilitation. Professor Burdekin explained in his speech at the launch that as a community we cannot afford to continue to turn a blind eye to the human rights abuses that are so prevalent in this area. This inquiry demanded an urgent response to these issues. So I was working as a mental health social worker when the Burdekin inquiry was launched in 1993. I'd even given a submission, and some of you may have actually been at school at that time, and dare I say it, some of you might not have actually even been born. Yet for all of us, I'm sure that this report sounds disturbingly familiar and still resonates. So my talk today will consider where have we got to on these issues raised by the Burdekin inquiry, particularly drawing on research that I've been involved in. One of the most important developments, as I was talking about last night, was 18 years ago with the United Nations Convention on the Rights of Persons with Disability, the CRPD. As many of you know, this is an international human rights instrument governing the rights of people with disabilities, and since Australia has become a signatory, we now have considerable expectation that mental health law, policy and practice will be in line with the Convention, with increased emphasis on human rights. The Convention recognises the need to address coercion and requires major reforms, including prioritising and protecting rights to community inclusion, autonomy, citizenship and empowerment, and to ensure people have access to coercion-free services that respect their dignity and legal capacity. The CRPD sets out positive entitlement of support for exercising legal capacity that allows people to seek help with making decisions, understanding information, or communicating their choices. There are different interpretations of the CRPD. One interpretation is that it should lead to a total ban on involuntary treatment. Another interpretation is that Article 12 tolerates the idea of us having compulsory treatment, but it should be for the shortest period of time and subject to safeguards and monitoring. Either way, there's agreement that the CRPD has an aspiration to reduce coercion and respect the rights, will and preferences of people. So the UN Special Rapporteur, since the CRPD, did a major call for reform, and that's really part of the transformation and innovation that's being driven by international activism and advocacy. So these quotes are from Danius Pouris, the UN Special Rapporteur on the Right to Health, in his final report to the Human Rights Council. They've not been without controversy, but form part of the increasing interest in the evidence and support for psychosocial interventions and new practice models, and the demand for a shift away from the biomedical, coercive and restrictive practices, and doing more to align with what mental health services to provide with people with what they actually want and need. These quotes express an ongoing frustration with the progress of reform, but I think they particularly offer hope by reminding us that people accessing mental health services are rights holders who can claim dignity and respect. And Amanda and Kerry are going to pick up more on Danius's work later on this afternoon. So moving forward, and we find more efforts in recent years. The Quality Rights is the World Health Organisation's global initiative to improve the quality of care provided by mental health and social services and promote the human rights of people with mental health conditions. Through Quality Rights, the World Health Organisation is supporting countries to put in place policies, strategies and laws and services that are in line with international human rights standards, including the CRPD. It aims to build community-based services that are person-centred and rights-based and avoid the use of coercive practices. Another objective is to engage civil society, in particular people with lived experience in decision-making and actions related to mental health, and to develop new policy and law frameworks that reinforce an integrated rights-based approach. And the Quality Rights Initiative is aligned with the concurrent work of the World Psychiatric Association in their call for action to implement alternatives to coercion. In Australia, an example is the Royal Commission into Victoria's mental health system, which was formally established in 2019 and delivered its first report in February 2021. The report outlined a bold 10-year plan to transform Victoria's mental health system from a crisis-driven, fragmented model into a responsive, community-based, person-centred system. It identified chronic underinvestment, coercive practices and poor integration with housing, physical health and substance use services as key failures in the current system. The proposed reforms included legislative changes and alignment with international human rights frameworks that underpin the vision for a compassionate, inclusive and effective mental health system. So as a result of the Royal Commission in Victoria, we now have the 2022 Mental Health and Wellbeing Act in Victoria. This is the second Mental Health Act I've had the privilege of being an advisor on. And the Act includes 13 principles, including the dignity and autonomy principle, the least restrictive principle, and the supported decision-making principle. And mental health and wellbeing service providers exercising a function under the Act and making a decision under this Act must make all reasonable efforts to comply with principles and give proper consideration to the principles. The new law is aligned with the intention to reduce the rates and negative impacts of compulsory assessment and treatment and restrictive practices, with an ambition to eliminate restraint and seclusion within 10 years. So I was part of a team that took a closer look at the work of the Royal Commission, and what we found was that policies and recommendations for reform tended to express an overarching concern that the current work of the system is under-resourced and that this represents its main problem. So the intention to decrease the use of compulsion and restrictive interventions is closely aligned with the need to better resource and expand the current system. More staff, more beds, more community services, improved access, etc. This is potentially neglecting deliberate discussion and action on the intersecting social factors that directly contribute to compulsory treatment. Is this really about more business as usual? And what if we consider what Patel and colleagues and others have suggested, that business as usual has failed and will continue to do so? So let's look at how we're going in the context of all this quest for reform. Current data suggests that compulsory psychiatric hospital admissions in Australia are not significantly decreasing, despite ongoing reform efforts. According to the Australian Institute of Health and Welfare, there were 206,000 overnight mental health-related hospitalisations in public hospitals in 2022 to 2023, and we can see here that many of these admissions are involuntary. These figures are based on the best available data from chief psychiatrist reports and the AIHW publications. They're estimates and should be interpreted with caution due to variations in reporting standards and data availability. However, they do appear to confirm that compulsory admission is commonplace, and there is no strong evidence that compulsory mental health hospital admissions are decreasing nationally. We also know that many of the people being admitted are initially caught in what's been described as emergency department bottlenecks, increasing the risk of distress and escalation, leading to increased risk of being restrained in the ED. Many of the studies that investigate the impact of compulsory treatment and care that include negative experiences are conducted with people retrospectively. So not just during the period of involuntary treatment, and they demonstrate the profound impact coercion can have on people over the long term. Many people subjected to coercive practices report experiencing them as a form of violence, trauma or re-traumatisation, leading to feelings of dehumanisation and disempowerment, and a worsening of their condition and increased distress. In other words, if anyone's hanging on to the idea that people will thank you later for your use of coercion or restrictive practices, the evidence really doesn't support such a position. In an international review, Walker and colleagues identified that previous involuntary hospitalisation and diagnosis of a psychotic disorder present the greatest risks for further compulsory treatment. This finding highlights opportunities for preventative interventions. Kath Roper, a respected lived experience researcher, and I wrote about this and suggested that the experience of coercion or being subject to restrictive interventions associated with involuntary admission can lead to disengagement with mental health services, setting up an ongoing cycle of involuntary admissions. Interrupting what has been described as a potentially spirit-breaking cycle demands attention. Walker and colleagues also found that if you are poor, you're more likely to be involuntarily detained, and also if you are from a poor area, suggesting that economic deprivation on an individual level and at the population level is associated with increased risk for involuntary hospitalisation. People from culturally and linguistically diverse backgrounds have higher levels of psychological distress, are more likely to be diagnosed with psychotic disorders, and more likely to come in contact with mental health services through negative pathways and experience restrictive interventions. Those negative pathways include rapid tranquilisation and seclusion and restraint. Many of these differences have been linked to increased exposure to racial discrimination and structural racism, which also increase exposure to other social determinants of mental health. We don't have a clear message about this in relation to other marginalised groups, particularly trans and gender diverse people. People are experiencing family violence and so forth, but they are likely to be relevant and compounding issues, considering what we know about intersectionality. In our national study on seclusion and restraint, one supporter from a culturally and linguistically diverse background described their experience of poor communication from mental health services during a time when her husband was being restrained in the ED. This participant thought she knew her husband better than anyone in this situation, but she was not consulted because English was not her first language and because of her cultural background. It was only when she rang and got English-speaking relatives to come that finally some information was being shared. The power of those stories. Thankfully, rates of seclusion and restraint in Australia have been found to be falling, as reported in the recent National Report Card. But despite 2 decades of policy efforts to reduce these practices, rates are still persistently high. Across Australia, a significant number of people experiencing acute mental health crises are subject to restrictive practices, such as seclusion and restraint in inpatient units, with more than 20,000 events reported annually, occurring daily in some units. Critically, nationally reported rates vary widely across inpatient units by up to 10 times. The Victorian Mental Illness Awareness Council, or VMIAC, the peak body for the mental health consumers in Victoria, have provided a consumer-led analysis of seclusion and restraint practices in public mental health services. The report focuses on transparency, accountability and human rights implications of restrictive practices. What they persistently find is significant differences in the rates of seclusion and restraint between hospitals and health services. Some services have consistently high rates, while others showed improvements or much lower usage. And this lower usage supports some optimism about the work towards elimination. The report also found a disproportionate impact on First Nations people, with 5% of people secluded being Aboriginal or Torres Strait Islander people, despite making up only 3.5% of admissions. Restraint rates were also higher for Indigenous patients, with raising concerns about cultural safety and systemic bias. The report found that there is no seclusion and restraint data for the LGBTIQA+ community, and little data could be obtained on gender diversity, which suggests that this isn't really being adequately recorded. The VMISC report includes first-hand accounts of trauma and harm caused by seclusion and restraint. It highlights the long-term psychological impact and deterrence from seeking future care. Going back to our research, I think this quote from one of our participants highlights the negative impact even a single experience of seclusion and restraint can have. So what I've seen with people who felt when they've had even a single 24-hour experience of seclusion and restraint under the mental health system, which is the door, the police, the medication, down into the whatever, the taking of the clothes, the whole lot, that person's changed forever in their feeling and their relationship to the society around them. To every other state agency, they're changed, and that's again that learned helplessness. So our evaluation of safe wards in Victoria, a model of care specifically focused on reducing seclusion, found that it did lead to a 36% reduction in seclusion rates at 12 months when implementing safe wards with high fidelity. But the success of these efforts required sustained organisational commitment. You need the engagement of a variety of staff who act as champions and opinion leaders. As Justine Fletcher, who did her PhD on this project, describes, safe wards depends on fidelity to the model and awareness of implementation strategies. You also need a supportive culture, and staff really need to be part of the implementation and confident in their role. And safe wards is a good example of how challenging it is to actually implement models of care designed to reduce coercive interventions and restrictive practices. So, just like seclusion and restraint, and despite 30 years of trying to reduce coercion, community treatment orders remain part of the landscape in Australia, but highly variable implementation across states despite general similarities in legislation and health services. and we see variation in the use of CTOs internationally. This chart gives some perspective on the varying rates of the use of CTOs in jurisdictions in Australia and across the world. One theory about this is that it's driven by fewer inpatient beds and shorter stays. Another is the lobster pot effect. Victoria is the state in Australia with the longest history of using CTOs, and people get trapped. It's easier to get on a CTO than it is to get off one. Another important issue in the implementation of CTOs is whether compulsory treatment is being applied in discriminatory ways. And we have some evidence of concern. Disproportionately high rates of use of CTOs are seen in minority groups. In New Zealand, for example, people of Maori descent are 4 times more likely to be on a CTO than non-Pacific people. In England, black people are reported to be between 7 and 10 times more likely than other groups to be on a CTO, depending on the study. In Australia, a systematic review of Australian studies found that people from culturally and linguistically diverse backgrounds were 40% more likely to be on a CTO than the general population. And a study in Queensland found that people who required an interpreter were 3 times more likely to be on a CTO. Several possible reasons have been advanced for this, including perceived discrimination, poverty, social isolation, racism, and reluctance to seek treatment. With First Nations people in Australia, studies have been less conclusive. So I'm very much caught up in the world of CTOs as someone who's been researching this area for over 20 years and also as a tribunal member. And what I'm persistently aware of is that CTOs, like other coercive practices, can have a negative impact on mental health and wellbeing and may undermine people's trust in mental health services. But CTOs can also have a negative effect on staff and services, including moral injury. Services and staff could potentially be de-skilled in relation to how continuity of care might be achieved without a compulsory order, even when the person is reluctant to engage or afraid of mental health services. Sharon Lawn and colleagues have suggested that the current mental health legislation appears to focus on the process of imposing CTOs, with little accountability for what happens to workers, services and patients during the CTO period. So the quote here is from research I did with Nick Owens when we did a file review looking at what happens when people are recalled to hospital when on a CTO. Admittedly, it was retrospective, but we commonly saw opportunities to work towards avoiding a variation or revocation. And we were also disappointed to see very little support being given to people and their families following this process, even though it was often a highly distressing experience. It seemed to be too commonly someone else or another team's job. So this is a recent publication from the Factors team that I'm leading, along with Professor Steve Kisley from here in Queensland. Like rates of seclusion and restraint, we've seen considerable variation in the use of CTOs between and within states in Australia. Each of these dotted vertical lines represents an individual health service, and what you can see here is that there is wide variation by health district in the proportion of mental health attendees on CTOs within jurisdictions. In New South Wales, it ranged from 2% to 13%, in Victoria from 6% to 24%, in Queensland from 11% to 25%, and in South Australia from 6% all the way up to 36%. So what accounts for this wide variation in CTO use across and within jurisdictions? Here's a potential list that have been suggested in the literature and in our discussions with stakeholders. It may be that where CTO use is low, they're more targeted and more effective, but CTO use may be lower where services are better, or lower in remote communities where implementation of a CTO would be more difficult due to resource limitations. Access to advocacy may make a difference. For example, in New South Wales, 83% of consumers who went before the tribunal had legal representation, whereas in the same year in Victoria, 13% were represented. The evidence for compulsory community treatment is highly contested. Randomised control trials that have been focused on readmission to hospital and other outcomes have not established evidence for the use of CTOs. And other studies, such as case control studies that have followed people over time, have found inconsistent and conflicting results. However, even if the evidence might be described as weak, this has not led to more cautious use of CTOs by some clinicians or services. CTOs appear to have increasingly served as an insurance policy in a depleted system, setting up an obligation for community services to follow up people coming off a relatively short admission to hospital and thus guaranteeing service delivery. There appears to be a sense that a CTO establishes an agreement between a person and a mental health service that they will receive follow-up. For some consumers and their treating team, it may feel like they have a guaranteed pathway into hospital admission if their mental health declines. Therefore, when CTOs do provide some benefit, it may be because they act as an administrative mechanism that perhaps stops people falling through the cracks of a siloed service system. However, limiting human rights to remedy service system failures is a very problematic, unintended consequence of CTOs. This strategic use of CTOs contributes to the potential for iatrogenic harm. It also contributes to not facing the challenge of developing engagement and relationship skills and making progress on other factors that are likely to be impacting on problems associated with continuity of care. So legislative change appears to have had a minimal impact on high rates of community treatment orders. It's very hard to find evidence about how to reduce the use of CTOs. In a recent we did an international search of peer-reviewed and grey literature led by my colleague, Chris Maley, and using international context for advice, and we have not been able to locate any evidence that jurisdictions have been able to reduce CTOs and how they did it. And this is really a very important challenge for the future. So we'll be further investigating this, but publicly available data in Victoria is suggesting that so far our 2022 Mental Health and Wellbeing Act has had minimal impact on the rates of use of CTOs, even though we did see a drop after the 2014 Act. So I've just slightly contradicted myself there because this new data did suggest that we did see a bit of a drop after 2014. And so the lawyers on the team are particularly happy to see that. But the only problem is that what we're seeing is that this lack of consistency in legislation actually having an impact. And it's interesting because in the rural context in Victoria, we see less CTOs, but we see this same pattern of this drop after the 2014 Act, but no similar drop after 2022, despite all the investment that went in to having a new piece of legislation. So it appears we need a range of strategies in place to realise human rights and reduce the use of coercion, especially when both evidence and law reform appear to only have limited impact. This situation requires identifying alternatives to coercion in mental health care and monitoring their impact. For example, in our statewide evaluation of prevention and recovery care services in Victoria, which are our step-up, step-down residential services, we deliberately included days on a CTO as an outcome, and our findings did suggest that a stay in a park may help reduce the use of a CTO. There's also hope that increased access to legal and non-legal advocacy will contribute, as well as enhancing the emphasis on supported decision-making, alongside a range of other person-centred and human rights-based approaches, and examples of good practice from around the world provided in the 2021 World Health Organisation guidance. As I've previously suggested, demonstrating genuine respect for legal capacity and supported decision-making, addressing power imbalances, shifting away from the dominance of the biomedical model and reducing the use of restrictive practices and coercive interventions requires considerable individual and systemic advocacy. Our research investigating the implementation of supported decision-making confirmed that supported decision-making can't rely on legal mechanisms like advance statements and nominated persons alone. Advocacy and peer support enables consumers to be more empowered to express their will and preferences, along with having staff who have the ability to engage with people and build trusting relationships. These activities also need supportive leadership and management that enables changes in practice and a shift towards service cultures that are genuinely person-centred and less risk-averse. It also relies on awareness of the need for culturally safe services and direct engagement with discriminatory practices. So now I come to one of my favourite slides, and I'm very thankful to Elise Rouhani for this fabulous image that sums up the social determinants of mental health. The social determinants of health framework emphasises that health disparities are largely shaped by social, cultural and environmental conditions rather than solely by biological or individual lifestyle factors. Sir Michael Marmot, a champion of social determinants, suggests that social determinants of health are no longer a guilty secret among academics, but he also questions whether the broader public, policymakers and institutions are translating this understanding into meaningful change. He continues to express concern about whether people are truly listening and acting on the evidence. In a 2025 opinion piece just this year in the BMJ, Marmon and Allen reflect on the progress made since the 2008 World Health Organisation Commission on Social Determinants of Health, which famously declared that social injustice is killing people on a grand scale. While it seems that awareness and measurement have improved, action on improving daily living conditions and addressing inequities in power, money and resources remains insufficient. Hundreds of thousands of Australians with severe mental illness live with preventable disability, economic disadvantage and poverty. And as we all well know, people with mental illness die 15 to 20 years earlier than everyone else. Considering these issues, Marmot argues that health equity requires structural changes, not just clinical interventions. For people with psychosis, this means improving access to stable housing, meaningful employment and community support, rather than relying solely on medication or hospital care. His emphasis on empowerment and participation in addressing social determinants aligns with the need to include people with lived experience in shaping mental health services and policies. Challenging oppression is an important aspect of enhancing the well-being of everyone, and particularly people with psychosis, and mental health interventions should be a force for transformation rather than conformity. Last year in a publication in World Psychiatry, Kirkbride and colleagues detailed 7 recommendations to address the social determinants of mental health. They include addressing poverty and economic inequality by implementing policies that reduce income inequality, improve housing stability and provide adequate social protection. Also promote safe and inclusive communities through fostering environments that reduce violence, discrimination and social exclusion, especially for marginalised groups. People with childhood trauma are 3 times more likely to develop psychosis. Zoe and colleagues' study is the largest and most comprehensive analysis to date. The evidence strengthens the case for trauma-informed services that recognise early adversity as central to serious mental health outcomes. Last year I was fortunate to attend a presentation by Taihu Afuapi, who asked us to consider, what if our forms of distress and resistance are forms of protest? She suggested that as well as trying to soothe, how can we acknowledge and bear witness to the experiences a person's distress are pointing to? She defines trauma as the distress we experience as a result of emotionally painful circumstances, often linked to forms of oppression, prejudice or abuse. Hence we need mental health care that starts by asking what happened to you and responds with compassion, but also takes into account social and structural factors in what's actually happening now. People with psychosis often face inequalities in access, experience and outcomes of mental health care, and it's disturbing to consider how often experiences of stigma and discrimination occur in mental health settings, including mental health care settings. This is featured in my research, both in our bowel cancer study, which has been investigating why people diagnosed with serious mental illness die more prematurely from bowel cancer than others with the same diagnosis, and also the poor support people often receive to gain help with giving up smoking. In SANE's National Stigma Support Card, more than 83% of our Turn to Speak participants reported experiencing some level of stigma or discrimination in accessing or receiving healthcare during the last 12 months. Of the 501 participants who selected healthcare as one of their top 3 most affected life domains, 60% of participants reported frequent or very frequent experiences of stigma and discrimination in this area. I hope you had time to read those 2 quotes that really highlight the kinds of difficulties that people are often facing within our own healthcare services. In all the efforts I've described so far related to respect for human rights, improving the quality of care, having a more recovery-focused service delivery system, and taking social determinants into account, the importance of people being heard and valuing lived experience has been central to the potential for reform, and that includes research efforts and implementation. And we have a couple of quotes there from the VMISC and also my lovely colleague Tessa Zernsak, who both represent efforts to ensure that lived experience is represented in research. We have an ongoing imperative to move evidence-informed approaches that provide alternatives to coercion or reduce the use of coercion from the margins to the mainstream. What we learned from the SHIP study way back in 2010 is that many people who may benefit from evidence-based psychosocial interventions are not receiving them, even though they are usually found to be helpful. And in my experience, people on CTOs are at particular risk of not receiving psychosocial interventions. A range of community-based social interventions have strong or promising evidence, but these are the most complex interventions to implement. Implementation requires not just financial commitment, but also appreciation of the importance of contextual factors and the need to make local adaptations. I had the pleasure of visiting the Tower Hamlets Centre, one of 6 new neighbourhood mental health hubs set to open across England this year based on the Trieste model. These centres will bring together crisis services, community mental health teams, short-stay beds, known as guest bedrooms, and I've actually got a photo of one there on the slide, as well as housing and employment support. People with conditions such as schizophrenia or bipolar disorder can walk in without an appointment and receive support from a team that includes psychiatrists, peer support workers and voluntary sector staff. The centres are designed to provide continuity of care, ensuring people are supported by the same trusted team throughout their recovery. They will also host local authority, faith and community organisations, creating a truly integrated support network. But this is just one example of the opportunities that need support, momentum and commitment from multiple sources. And we do have examples of efforts in Australia as well. Unfortunately, we have really a nation of pilots and not enough of these pilots turn into mainstream commitments. Nicholas Rose finds himself being positive about the potential for a focus on social determinants, but reminds us that this requires a paradigm shift and perhaps, indeed, this could represent our next big opportunity for transformation and reform. So what are the implications for research? Most importantly, we need to scale up these different and innovative ways of working and monitor the impact on coercion and restrictive practices so that we enable accountability for our reform efforts. It's no use having a lot of reforms that actually aren't impacting on this pointy end of the system, in my opinion. A possible template for addressing inequalities is the NHS England's Advancing Mental Health Equality Strategy. It specifies 4 key steps. Identify the inequalities, and this includes using existing data and working with communities. Design new ways of doing things. This includes research to explore what could be done to solve these issues and exploring what is already being done, then formulating plans for action, including setting out the key priorities, deliver improvements. This involves creating and implementing a strategy, evaluate those ideas, and this requires data collection, providing opportunities for feedback and involvement, and analysis of this information to inform further progress. So finally, in conclusion, respecting human rights, addressing inequality and the social determinants of mental health are linked. It requires embedding human rights and principles of equity, dignity and inclusion in legislation, policy and practice. Support for research efforts that provide the evidence needed to reduce coercion and restrictive practices. Investment in social supports, particularly poverty alleviation, housing, education, employment. Strengthening community-based services and peer-led initiatives. Integration of support, cross-sector collaboration and continuity. And together we can transform mental health care and remain on the visionary journey expected in 1993. Thank you. And I have to thank TJ who put together all these references. But anyway, if you want to see whether I can back up my claims, there they all are. Thank you.